We now have a quorum, and so we'll go ahead and get started. Welcome to this meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meets has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DURB board members, reserve questions until the end of presentations or ask in the Google Meet chat. For those of you providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DURB board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process moving forward. And now I'll turn the time over to Dr. Weinstein.
Good morning. Welcome to our June DURB meeting. Calling to order, and our first order of business today is to review the minutes from the May meeting. I hope everybody's had a chance to look at them, and if you have any suggestions for revisions, please let us know. If not, I'll take a motion to approve the May minutes.
Move to approve.
And a second, please.
I'll second.
Thank you. All in favor of the May minutes? Aye.
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 Thank you. Okay, I think the next item in our agenda is if we have a P&T committee update. Is that correct?
Yes, I can give a P&T update. Good morning, everyone. So in May, the P&T committee has met to review the ALK, MET, and RED selective inhibitor for oncology. There won't be any P&T meeting from now until the next meeting will be in September to review Botox for the placement on the PDL. Thank you.
Thank you. And Dr. Weinstein, I'm going to go ahead and provide some housekeeping items, if that's okay.
Oh, yes, of course. Thank you.
Okay, thank you. So the Utah Medicaid Pharmacy team would like to mention an update. Due to recent updates to our telephonic system, telephone options have changed. Please contact us with the new option regarding pharmacy questions at the same phone number, the 801-538-6155. But this time it'll be option 1, and then option 1 for the pharmacy prior authorization team, or option 2 for the clinical outreach services. So it's a quicker options there for the phone tree. And then also we would like to provide an update, and this is all part of the July mid that will be sent out to providers. But there's been an update for the opioid use in pregnancy. And it says pregnant members are limited to a 7-day supply of opioids. Prior authorization is required to override this limit for pregnant members. Effective July 1st, 2025, if the pharmacist has verified that the member is not currently pregnant, they may use submission clarification code 10 to override the 7-day supply limitation. And then additional information is available at medicaid.utah.gov for the pharmacy program at the website. All right, and then we also have an update regarding the process for the DURB board meetings. We thought it would be better, more transparent and clear if when recommendations are made during the DURB board meeting regarding PA criteria, that we just bring it back for the following meeting and provide an update as to what was changed on the PA form. And also to update the DUR board if the PA criteria has been posted as approved in the previous meeting. And so that will start with the July meeting, just so everyone knows. But yeah, it's a new update on the process there. Next is for the dispense as written 1 or DAW 1 update. So effective July 1st, 2025, according to HB 347 from the 2025 general session, when the provider writes dispense as written on the prescription, pharmacist claims DAW1 code will no longer override the preferred drug list for the psychotropic drugs, including antidepressants, anticonvulsants or mood stabilizers, anti-anxiety medications, and attention deficit hyperactivity disorder stimulants. The non-preferred psychotropic drugs will be covered if the department, based on member claims history or healthcare provider attestation, has evidence of trial and failure of a psychotropic drug on the preferred drug list that is equivalent or similar to the drug that is not on the preferred drug list in the last 365 days, or the member being stabilized, meaning that the enrollee has achieved a stable or steadfast medical state within the past 90 days on the non-preferred psychotropic drug. The DAW1 code remains to override the non-preferred products listed on the preferred drug list for antipsychotic medications. Check boxes or pre-printed forms that include dispense as written are not acceptable substitutes for the prescriber writing dispense as written on the prescription. Also of note, the DAW1 code will not allow claims for the brand name version of multi-source drugs to process, even though the brand name version of the drug is listed as non-preferred on the prescriber, and the prescriber writes dispense as written on the prescription. If a Medicaid member needs the brand name version that is listed as non-preferred, a prior authorization request must be submitted to Utah Medicaid using the medication coverage exception request prior authorization form. And also, we wanted to provide an update on the weight loss policy. Effective July 1st, 2025 through SB 3 appropriations adjustments from the 2025 general session, select GLP-1 agonists, including Wegovy, Saxenda, and Zepbound, will be covered for fee-for-service members. The coverage criteria is for children that have BMI greater than or equal to 95th percentile, and for adult members with diagnoses of obesity with BMI greater than or equal to 30, or overweight with BMI 27 to 29.9, and at least one weight-related comorbidity. Additional criteria is listed on the GLP-1 medications for weight loss prior authorization, which we'll go over today with the board. We'll be sharing that criteria. The provider can find and submit the GLP-1 medications for weight loss prior authorization form available at medicaid.utah.gov and request the GLP-1 medications for weight loss. Other non-GLP-1 agonist weight loss medications remain non-covered. So that is it in terms of housekeeping. Thank you so much.
Thank you again for those updates, and I'm sure as any of our board members may refer to those published policies, and please direct any questions if they arise. Thank you so much. That's a lot, I think, of administrative improvements to increase the efficiency of service to our members. So thank you so much for that. I think we are now on to item 3. It is our annual open public meeting training. And I believe we have Tony Patterson, if that's correct, to provide us with that training.
That is.
I'll turn it over to you. Thank you so much.
Thank you, Doctor. I appreciate this opportunity to have a brief review of the Open and Public Meetings Act. This is required by Utah law to be conducted annually. I'm aware that most of you have received similar training in other boards or committees or in this particular board. And so it is not intended to be a detailed review, but more of a general overview. So to begin with, just as a reminder, the Open and Public Meeting Act is our sunshine law for the state of Utah. On the federal level, most people are familiar with the term acronym FOIA. The purpose of the Open and Public Meeting Act is to ensure that the government, its agencies, the political subdivisions are acting and deliberating openly to promote public trust and participation in the development of policy in the state of Utah. Before the meeting, there must be notice provided of the date, time, and place of the meeting. It must be at least 24 hours. And the items listed on the agenda to be discussed must be of sufficient specificity so that a reasonable individual would understand the topic that is going to be discussed during the meeting. Now, we need to keep in mind that during meetings, and this slide is just dealing with the electronic meetings, which I believe we're all familiar with. The details of it, I believe the staff have done a great job complying with it, so I will not spend time on it. But during the meetings, it's important to remember that it is being recorded, that everything you say may and can be used in a newspaper or a court of law, which often is the worst place to be quoted. Now, during the meeting, it is important to limit discussions to those items that were discussed on the agenda. If a member of the board or a public member brings up an issue, that may be discussed. However, it may not be voted upon, it may not be acted upon. There cannot be any formal decision made until there has been notice and an opportunity for the public to be aware of the issue and participate if they so desire. Text messaging, really, and other forms of messaging is really discouraged during meetings. I actually had a hearing one time where there were various board members of this particular board that were texting back and forth. This was back in the BlackBerry days, and the opposing counsel became aware of it and was demanding that those board members make public their entire phone and all of its text messaging so they would be aware of what was being discussed between the board members so they would have a fair opportunity to respond to it. That was quite disruptive for the meeting, and so the best policy is not to engage in texting or other forms of communication during the meeting. Disruptive behavior does not have to be tolerated. If an individual would like an opportunity to speak, there is time limits. There are allocations of ways that can be addressed. However, if they do become so disruptive that it is derailing the meeting, those individuals may be removed from the meeting. There are limited purposes for which a meeting may be closed. Those are specifically set forth in statute. And I will note that in Utah, the most common areas that are being challenged in court are dealing with the adequacy of notice. It deals with board or committee members discussing items in a closed meeting that is not permitted by the statute, or actually meeting without providing any notice whatsoever. So those have been the areas that have been adjudicated in court in Utah thus far. After the meeting, there is a requirement that all of the materials that were submitted that the board considered as part of its decision-making process, as well as the recording, be posted. Draft minutes must be posted within 30 days, and approved minutes must be posted within 3 days. That is, of course, on Utah's public notice website. Now, there are penalties, and this has happened on a number of occasions where courts have voided actions taken by various government entities or public bodies, and have set them aside, requiring the public body to readdress the issue. Now, while there is a potential for a Class B misdemeanor for violating the Open and Public Meetings Act, I'm not aware of actually any criminal prosecutions that have occurred this far. Now, we were fortunate this past legislative session. There were no updates to the Open and Public Meetings Act this time. Usually there is, but this time the legislature apparently were dealing with other issues. So with that, that is a brief overview of what must occur before the meeting, what occurs during the meeting, and after the meeting, what must be taking place to comply with the law. At this point, I'll open it up if anyone has any questions that they would like to ask. I'll take that as a good sign. If there are any questions, feel free to email me. This is my address. I'll wait just a moment, and then I'll take that down so that that's just a different comment, so I don't need to worry about that. So thank you, everyone. I appreciate your attention this morning. And with that, I'll drop off the call. Thank you.
Thank you so much for that update and for all the collaboration to make sure that we are following all of our relevant oversight rules and regulations. Very much appreciated your time today. Thank you.
Thank you.
Okay, we are going to make a slight adjustment to the order of business in the agenda. Our next item then coming up for review, we will go to I think, are we going to the Trivio item C4C first then?
Yes, Dr. Weinstein.
Okay,
let's proceed
I'll
with.
turn it over to you, Dr. Moreno.
Sorry.
Thank you.
Sorry, let's continue with Dr. Lulu presenting on Trivio, and then we'll go ahead and review the PA criteria after her presentation. And then after review of the Trivio PA criteria, we'll review GLP-1 medications for weight loss, and then Zynteglo PA criteria will be the final criteria we review today. Thank you.
Okay, good morning, everyone. Today, I'll be reviewing aprocitentan, or Trivio, the first FDA-approved endothelin receptor antagonist for the treatment of hypertension, which is indicated as add-on treatment for adults with inadequately controlled blood pressure while on other medications. Resistant hypertension is generally defined as an elevated blood pressure that remains above goal despite lifestyle changes and the concurrent use of a regimen of 3 or more antihypertensive agents from different drug classes at maximally tolerated doses. Resistant hypertension is estimated to occur in approximately 10 to 30% of patients diagnosed with hypertension, a condition that affects nearly half of the U.S. adult population. True resistant hypertension differs from apparent resistant or pseudo-resistant hypertension, in which true resistance to pharmacologic treatment cannot be confirmed and or other factors contribute to the elevated blood pressure rather than actual treatment resistance. The diagnosis of true resistant hypertension requires confirmation that the patient has an above goal blood pressure despite receiving at least 3 antihypertensive agents at maximally tolerated doses from different drug classes with complementary mechanisms of action. While some clinical practice guidelines are vague about the antihypertensive drug classes that should be part of the multi-drug regimen other than a diuretic, other guidelines are more specific, describing that the regimen should include agents from guideline-recommended first-line drug classes, including a thiazide or thiazide-like diuretic and an angiotensin-converting enzyme or ACE inhibitor or angiotensin receptor blocker or ARB, and a calcium channel blocker or CCB. According to the 2017 American College of Cardiology and American Heart Association hypertension algorithm, resistant hypertension also includes patients who require 4 or more antihypertensive agents to achieve their blood pressure target. To establish a diagnosis of true resistant hypertension, pseudo-resistance should be ruled out by verifying the patient is adherent to the prescribed antihypertensive regimen and ensuring that uncontrolled blood pressure is not due to other causes, such as secondary hypertension, white coat effect, suboptimal antihypertensive treatment, and inaccurate blood pressure measurements. Aprocitentan is an oral dual endothelin receptor antagonist that offers a novel therapeutic approach to lowering blood pressure by targeting the endothelin pathway. It was approved by the FDA in March 2024 for the treatment of hypertension in adults with inadequately controlled blood pressure while on other medications. Aprocitentan is intended to be used in combination with other antihypertensives. The labeled indication for aprocitentan does not specify that candidates for therapy should have resistant hypertension or the number of type of antihypertensives that must be used concomitantly with aprocitentan. However, as we will see on a later slide, the aprocitentan pivotal phase 3 clinical trial, Precision, enrolled adults with resistant hypertension who had a history of uncontrolled blood pressure despite treatment with at least 3 antihypertensive medications from different drug classes. We reviewed 2 US-based hypertension guidelines for pharmacotherapy recommendations regarding the treatment of resistant hypertension. A 2025 guideline from the American Diabetes Association, or ADA, and a 2020 guideline from the Department of Veterans Affairs, Department of Defense, or VA/DoD. Additionally, we reviewed an older 2018 American Heart Association, or AHA, scientific statement specifically addressing resistant hypertension. To supplement US-based guidelines, we also reviewed the 2024 guideline by the European Society of Cardiology, or ESC. As all reviewed guidances predated FDA approval of aprocitentan and did not address its use, we also reviewed expert guidance from UpToDate. Guidances from the ESC, AHA, and UpToDate recommend a structured stepwise pharmacotherapy approach for treating true resistant hypertension. For patients inadequately managed on a multi-drug regimen, including at least 3 antihypertensive agents from different drug classes, the approach generally is to escalate treatment by optimizing the diuretic and/or sequentially adding agents of different mechanisms of action in a stepwise manner until blood pressure is controlled. If not already tried and as clinically appropriate, several guidances suggest switching the existing diuretic in the regimen to a more potent thiazide-like diuretic. All reviewed guidances recommend the addition of a mineralocorticoid receptor antagonist, or MRA, as a 4th agent. While some reviewed guidances do not express an overall preference regarding the MRA used, both the VA/DoD and ESC specifically recommend the addition of spironolactone. If an MRA cannot be used, alternative options are the potassium-sparing diuretic amiloride or a beta blocker, depending on the guidance. For patients requiring further escalation, treatment decisions are often guided by patient-specific factors as limited evidence, if any, is available to inform the optimal 5th antihypertensive agent. In general, a beta-only blocker or combined alpha and beta blocker is recommended to be added next, depending on the patient's heart rate and if not already used. If a beta blocker is contraindicated, a central alpha-2 agonist can be considered. Experts from UpToDate update described that aprocitentan is also a treatment option as a fifth agent for resistant hypertension. Referral to a hypertension specialist or center is advised by the AHA when blood pressure is not improving as anticipated under primary care. Up-to-date experts recommend referral in cases where blood pressure remains uncontrolled after 6 months of intensive treatment with at least 3 additional antihypertensive agents as recommended in the stepwise approach, or if secondary hypertension is suspected. The ESC recommends earlier referral at the point when resistant hypertension is suspected. Notably, there are only 2 certified hypertension specialists and 7 certified hypertension clinicians in the state, according to the online American Hypertension Specialist Certification Program directory. The FDA, excuse me, the FDA approval of aprocitentan was based on Precision, a pivotal phase 3 multi-center trial. This trial evaluated the efficacy and safety of aprocitentan as add-on to standard of care therapy in adults with resistant hypertension. During the screening period, all participants transitioned from their existing antihypertensive regimen to standardized background antihypertensive therapy that included amlodipine, valsartan, and hydrochlorothiazide, administered once daily as a single oral tablet at the maximally tolerated fixed dose. This regimen was continued for the entire duration of the study. Participants concomitantly receiving a stable dose of a beta blocker for any indication started at least 4 weeks before screening were permitted to continue the beta blocker during this study in addition to standardized background therapy. Eligible adults were required to have a mean office sitting systolic blood pressure of greater than or equal to 140 millimeters of mercury despite treatment with 3 or more antihypertensive medications from different drug classes. Participants were excluded from the trial if they had secondary causes of hypertension, except for obstructive sleep apnea or other contributors to pseudo-resistant or apparent resistant hypertension, severe renal or hepatic impairment, a history of recent cardiovascular events, among other criteria. Part 1 of the study was a 4-week randomized double-blind placebo-controlled phase during which the primary endpoint was assessed. In this part of the study, participants were not allowed to use additional blood pressure affecting medications, including MRAs or high doses of loop diuretics. However, they were allowed to add a different diuretic, including low-dose loop diuretics, or increase the hydrochlorothiazide dose to treat fluid retention at the investigator's discretion. In the overall study population of randomized participants, the median age was 63 years at baseline. Based on medical history, the most prevalent comorbid conditions were type 2 diabetes, ischemic heart disease, and congestive heart failure. At study entry, 37% of participants had been receiving 3 antihypertensives, nearly half had been receiving 4, and approximately 17% had been receiving 5 or more, with almost all receiving a renin-angiotensin system blocker, followed by diuretics, CCBs, and beta blockers. At randomization, after having switched to the standard background regimen, 71% were receiving the highest fixed dose containing amlodipine, 10 milligrams, and 58% continued the regular beta blocker. For this presentation, I will focus only on the results for the primary endpoint, which was assessed in Part 1 of the study. This is the only part of the trial that evaluated the FDA-approved dose of aprocitentan. Please see the report for additional details. For the primary endpoint of change in mean trough sitting systolic blood pressure from baseline to week 4, a significantly greater decline was observed with both aprocitentan 12.5 milligrams and the higher non-FDA approved dose of 25 milligrams compared to placebo. The treatment effect was numerically similar between the lower and higher aprocitentan doses. According to sensitivity analysis, results were not affected by adding a diuretic or increasing the dose of hydrochlorothiazide. Additionally, there was no observed difference in treatment effect between participants who were receiving beta blockers at screening and those who were not. Adverse events, or AEs, were reported in 28% and 37% of participants in the aprocitentan 12.5 milligram and 25 milligram groups, respectively, compared to 19% in the placebo group. The most common AE was edema or fluid retention, which was generally mild to moderate in severity and more frequent with aprocitentan than placebo in a dose-dependent manner. Notably, about 45% of participants treated with aprocitentan 12.5 milligrams experienced edema or fluid retention and required additional diuretic treatment. Anemia occurred only in participants receiving aprocitentan, with no events reported in the placebo group. Aprocitentan is contraindicated in patients with a known hypersensitivity to the active ingredient or any component of the formulation and during pregnancy due to the potential risk of embryo-fetal toxicity, which is a black box warning. Other labeled warnings include the potential for hepatotoxicity, fluid retention, decreased hemoglobin, and reduced sperm counts. Before starting aprocitentan, patients who can become pregnant must have a confirmed negative pregnancy test. Additionally, patients should use effective contraception before and during aprocitentan treatment and for 1 month after stopping its use. If pregnancy occurs, aprocitentan should be discontinued as soon as possible. Prescribing information advises against starting aprocitentan in patients with elevated aminotransferase levels, moderate to severe hepatic impairment, or severe anemia. With respect to developing drug-specific prior authorization or PA criteria for aprocitentan, we recommend requiring that patients be at least 18 years of age based on the FDA-approved indication. While the labeling of aprocitentan states that it is approved for patients with inadequately controlled blood pressure on other medications, it is reasonable to specifically require that patients have a diagnosis of resistant hypertension, as this was the population in which efficacy was established in its pivotal clinical trial Precision. Additionally, you may require provider attestation that the patient has true resistant hypertension by excluding apparent resistant and pseudo-resistant hypertension. You also may require the patient to have previously tried or currently be receiving a combination of at least 3 guideline-recommended first-line antihypertensives from different drug classes, unless contraindicated or intolerant. If a patient is receiving a 3-drug regimen, including non-first-line antihypertensive agent instead of general first-line agents, consider allowing the prescriber to provide clinical justification for its use and allowing access to aprocitentan. Because the AHA also defines resistant hypertension to include patients who achieve their blood pressure goal on 4 or more antihypertensive agents, patients desiring to switch their 4th or later line agent to aprocitentan due to intolerance may also be considered for coverage. The provider may attest that the patient was previously diagnosed with true resistant hypertension. If desired, additional PA criteria could also be considered based on provider attestation and/or clinical documentation, such as those listed here. You may consider step-through therapy with an MRA as an additional add-on option for resistant hypertension. All reviewed guidances, most of which were published prior to the approval of aprocitentan, recommend adding an MRA as a 4th antihypertensive agent to a 3-drug regimen at maximally tolerated doses. Expert opinion and up-to-date, which addressed both MRAs and aprocitentan, suggests trying an MRA first according to their stepwise treatment approach and adding aprocitentan as a 5th agent if needed. Yet it should be considered that reserving aprocitentan as a 5th add-on agent would be more restrictive than the FDA indication, as efficacy was established as a 4th or later add-on option. Another idea is to require that aprocitentan be prescribed by or in consultation with a cardiologist or provider specialized in treating hypertension. Thank you for your time and attention.
Dr. Moreno, are we we going to any public comments? Sorry, I'm juggling the agenda.
Yes, no, I'm sorry. I need to do better at being clear
No.
with the agenda. So thank you for your flexibility. So correct. Now we're going to hear from Logan Poole with Novo Nordisk on GLP-1 medications, and then after him, we'll start with the prioritization criteria for trivial GLP-1 medications for weight loss, and then Zynteglo. Thank you.
Thank you so much.
Thank you. Hi, my name is Logan Poole, and I'm a pharmacist and medical account associate director with Novo Nordisk. I want to thank the board members for their efforts in moving the obesity coverage forward and appreciate the commitment to addressing obesity in the state of Utah. I recognize today we are going to talk about the criteria for GLP-1s and obesity. And as this body of evidence continues to increase for Wegovy, I wanted to be available to answer any questions you may have and be a resource. I will respectfully defer my remaining time back to the board. Thank you.
Thank you, Dr. Poole. And now we'll turn the time over to Iris, Dr. Wan.
Good morning. Let me just share my screen. Is everyone able to see it?
Yes, thank you.
Yes. Could you make
Perfect.
it
So,
a bit zoom in?
is that better?
Yes.
Okay, perfect. So this is the PA criteria for Trivio, aprocitentan. The first criteria is if the patient is 18 years of age or older. Does the patient have a diagnosis of treatment-resistant hypertension? If the patient is biological female and has reproductive potential, does the provider attest that the patient is not currently pregnant? Include a pregnancy test result, and has the provider counsel the patient on using effective contraception before starting, during, and for 1 month after discontinuing treatment. Has the provider counseled the patient to stop aprocitentan when they become pregnant? Has the provider assessed serum aminotransferase levels, ALT and AST, and total bilirubin levels obtained within 6 months prior to starting treatment and plan to monitor as per prescribing information? Does the provider attest that the patient does not have moderate or severe liver impairment, Child-Pugh class B or C? Does the provider attest that the patient does not have heart failure, New York Heart Association class 3 to 5, unstable cardiac function, or NT-proBNP greater or equal to 500? Does the provider attest that the patient does not have severe anemia, hemoglobin level of less than 8? Does the provider attest that the patient does not have kidney failure with eGFR less than 15 or is on dialysis? And then, has the patient concomitantly received at least 3 antihypertensive medication from different drug class? So ACI, ARB, CCB, and a diuretic, each at a maximally tolerated dose not to exceed the max recommended dose, but no less than the commonly recognized minimum therapeutic doses for at least 4 weeks, and continue to have uncontrolled blood pressure. And we just have a chart listed for each class. So angiotensin converting enzyme inhibitor or angiotensin 2 receptor blocker, long-acting calcium channel blocker, and then thiazide like diuretics, loop diuretics, and mineralocorticoid receptor antagonists, and then other classes. Now, will Trivio be used concurrently with other antihypertensive therapies, the medications and doses? And then for the reauthorization criteria, has the provider submitted an updated letter with medical justification or updated chart notes demonstrating positive reduction in sitting SVP from baseline? Does the patient continue to take concomitant antihypertensive therapy at maximally tolerated dose? And we have listed the box warning for embryo fetal toxicity, as it can cause major birth defects if used by pregnant patients. In patients who can become pregnant, obtain a negative pregnancy test prior to initiation of aprocitentan, and counsel patients to take monthly pregnancy tests during treatment and 1 month after discontinuation of aprocitentan to prevent pregnancy. Patient who can become pregnant should use acceptable methods of contraception before the start of, during, and for 1 month after stopping treatment. Any questions or concerns?
Dr. Smith?
Yeah, can everybody hear me?
Yes.
Great, thank you. Scrolling up to kind of the top of the list of criteria there. Biological female is not a real clinically useful term. Can we just simplify this to say people capable of becoming pregnant?
Absolutely.
Thank you.
Appreciate that suggestion for clarity, and I think I would make that a note for any, future documents where it might also be relevant. I don't think that substantially changes the intent there. But do we need an amendment, or just a wording suggestion, clarification? That's an administrative question. Dr. Moreno, do we need a amendment to the suggested PA criteria for that language change? Or can we just make it a edit?
Yeah, I believe that's a simple edit, just on the wording.
Okay, thank you.
Thank you.
Any other comments or questions from the board? This area of practice is outside of my general scope. My primary care background is very limited to this. And so the complexity, I think, is really evidenced here. And if there are any board members or anyone else participating who has expertise to make any further comments, it looked like we were being very conscientious with the criteria here, and in a couple of aspects, just clarifying for that stepwise projection in the use of multiple medications for this difficult condition. Does anybody else have any other comments or questions? If not, I would take a motion to approve the PA criteria for Trivio.
This is Laura Britton, motion to approve.
Second.
Thank you. All in favor, please indicate so. Aye.
Aye.
Thank you very much. I think we can move on to the GLP-1s.
Okay. Hello, everybody. Does everybody hear me okay? Okay, perfect. So this is GLP-1 medications for weight loss. Before I start on the criteria, so for patients with the obstructive sleep apnea, they can refer to Zipbound PA form, and for patients with major cardiovascular adverse events, they can refer to Wegovy PA form, and for patients with type 2 diabetes, different criteria apply for them, so they can refer to the Medicaid preferred drug list. Okay, the first criteria is does a patient have a diagnosis of one of the following? And for pediatric patients, they can see the additional criteria for Saxenda and Wegovy below. So they can put obesity with the defined as BMI 30 or greater, and then they can put baseline weight, height, BMI, and current BMI. For patients with overweight with BMI 27 to 29.9, and at least one weight-related comorbidity, for example, hypertension, dyslipidemia, history of myocardial infarction, stroke, peripheral artery disease, heart failures, and etc. And then they can list the weight-related comorbidities here, and then they can put the baseline weight, height, BMI, and current BMI. The second criteria is during the past year, has the patient tried strict lifestyle interventions for at least 6 months, including aerobic exercise, resistance training, and reduced calorie diet prescribed by a registered dietitian and did not attain at least 5% weight loss from the baseline. And then they need to include the consult note from dietitian. And then they can list the exercises and duration, reduce calorie diet and duration. And if the patient has not tried lifestyle interventions, they can provide rationale here. And the third one is, will the patient continue medically appropriate exercise programs and calorie restricted diet supervised by registered dietitian? And if they cannot continue the lifestyle modification, they can provide rationale here again. And does the provider attest that the patient is not taking another GLP-1 or GIP and GLP-1 receptor agonist medication? Does the provider attest that the patient has no personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2? If the patient is a biological female with reproductive potential, does the provider attest that the patient is not pregnant? And then we can reword the biological female here, just like the trivia. Does the provider attest that the patient does not have type 1 or type 2 diabetes, obstructive sleep apnea, or major cardiovascular adverse events? And here's the additional criteria for Saxenda. Is the patient 12 years of age or older? And if the patient is under age of 18, does the patient have BMI greater or equal to 95th percentile for age and sex? Does the provider attest to evaluate weight loss as follows and discontinue liraglutide if weight loss is not at the goal? For adult patients, is weight loss at least 4% from the baseline at week 16. And for pediatric patients, weight loss at least 1% from the baseline at week 12. And additional criteria for Wegovy, is the patient 12 years of age or older? And if the patient is under age of 18, does the patient have BMI greater or equal to 95th percentile for age and sex? Additional criteria for Zepbound, is the patient 18 years of age or older? And for reauthorization criteria, has the patient lost at least 5% of the weight from the baseline? Is the patient still being followed by a registered dietitian or nutritionist? And they need to include the updated consultation notes. Has the patient been adherent to and will continue with strict lifestyle interventions such as reduced calorie diet, aerobic exercise, and resistance training? And additional reauth criteria for Saxenda. For patients 18 years of age or older, will the patient continue at 3 milligram daily? For patients 12 to 17 years old, will the patient continue at 2.4 milligram or 3 milligram daily? And for additional criteria for Wegovy, will the patient continue at 1.7 milligram per week or higher? And for additional criteria for Zepbound, will the patient continue at least 5 milligram per week or higher? And then the initial and reauthorization will be up to 6 months. And then here are the black box warnings. Okay, any questions? Yes, Dr. Simonetti?
Yeah. Hi, good morning, everyone. So I am the director of the Comprehensive Weight Management Program here at the University of Utah and see patients for obesity. With the requirements, I understand the requirements for lifestyle modification, but it seems very strict. We have limited RDs that can see the patients. We do require our patients to see RD, but the requirements that you place, I think, would be really hard for patients to follow that consistently. And also the 1 year before, right? Was it a 1 year beforehand that or 6 months?
Yeah, for at least 6 months before before submitting the PA.
Okay. Because oftentimes with the times the patients come into the clinic to see us, and I understand this is
Excuse me, Dr. Simonetti, I'm sorry, for those providing public comment, we require a conflict of interest form be submitted to us prior to the meeting. And so
okay. Okay,
without
I'm sorry, I had it done previously. I thought that would count, so I'm sorry.
Oh, thank you so much. Yes, Dr. Britton, sorry.
Okay, looks like
Dr.
Dr. Britton.
Britton, you're muted.
Sorry, I was muted. Sorry about that. To address first Dr. Simonetti's question about the criteria, I think should be made aware that the funding for this weight loss is limited. So just keep that in mind, and that it was, I believe, approved based on calculations made according to criteria that would be proposed. The second thing I wanted to mention is that we have such a hard time with the comorbids in this policy because there's some that are excluded because they're in MACE, they're in OSA. So I just wanted to recommend under the overweight criteria and the comorbid that we strike the history of MI and stroke as being covered under the MACE criteria.
Okay, that's a really good suggestion. Yeah, yeah, that totally makes sense to strike that to remove the redundancy with the Wegovy. Thank you.
Dr. Smith?
Yeah. Yes, Dr. Smith.
In line with the requirements for exercise and diet, I was wondering if we could consider adding a statement to the end of this that says something to the effect of unless contraindicated. If there's someone who truly should not be or can't attempt.
Yeah, so to address any contraindication like disability or anything else, they can put the rationale here. So if they did not try it or cannot continue with the lifestyle, they can put the rationale here in the 2 and here 3.
Mm-hmm.
I think it also there says medically appropriate programs, and following on to the conversation about access to all of the supportive cares or related cares that have to do with lifestyle change. I think this is a recurring theme for us in this board where we have discussed in relation to other PAs and other regulations, requirements for certain concurrent cares in mental health, in lifestyle. My background in pain medicine, so the evidence base for non-pharmacologic care such as CBT and other things all depend on access. So I think this is a delicate a point to try to incorporate here. So I was just trying to think of some language aside from the medical appropriateness, or if there are medical contraindications to their participation in any of these other things. But I think there's also the concern about accessibility for some of the other services. So I don't know if anybody else has a thought about how we might incorporate a statement that indicates, the patient has done everything they can do with the accessible services. Any other thoughts on that? Dr. Siegfried?
I'm just going to read off the state of Virginia's sort of prior authorization language. Some of it includes participation in nutritional counseling, participation in physical activity program unless medically contraindicated, and commitment to continue sort of the above, or I would say individualized weight loss treatment plan, as something more general as opposed to more, specific and strict requirements potentially.
And in that general provision, do we want to, include some wording, as recommended? I think that's what the intention is, correct?
Correct. And it was included under a section for written documentation, that it be included as part of their essay form.
So if we're just looking at number 3 here, which is up on the screen, for example, will the patient continue? I think that language that you provided from Virginia says, is the patient make a commitment, or has the patient made a commitment to continue? I think that would, we could switch out that language a little bit. And under the diet, is it as recommended by a dietitian? Or, if we say supervision, that would imply, recurring appointments, which I think is some of our colleagues' concern that there may not be access.
Okay, that's a great suggestion. Thank you. Yeah.
Yeah, just a comment, with some of this criteria, appearing a little more restrictive, it's just that the pharmacy team is concerned about not having like unlimited funding for this. And so we wanted to approve for the people that need it the most, that are most committed, in terms for their weight loss goals.
Understood. Dr. Britton?
I just wanted to remind everybody that this is strictly for fee-for-service, that this would not be covered under the ACOs the way we normally would apply a benefit. So this is strictly for fee-for-service.
Good point. I just have a quick content question on the sections where we have baseline BMI and current BMI. I'm not sure I understand what the difference is between those two.
Yeah, I think this is at the baseline before try the lifestyle intervention, and then they can so they can put the baseline BMI before they try any like lifestyle modification or other pharmacologic therapies, and for current BMI they can put the like BMI after the try. So yeah, but please correct me like if I'm wrong, other pharmacists.
It's a question. It's a question, as I don't work in these clinics. I mean, I have patients on these medications, but would the usual healthcare professional filling this format, would they understand the difference? Is there like a standard interpretation of what the baseline would mean?
Maybe not unless they had been seen before, right, in the clinic. The only other time I could think of this if they had been seen and had used other meds and had lost some weight, and now they have a different current BMI.
Thank you.
It might be more appropriate just to list baseline BMI prior to the use of these medications, and then for reauthorization, what their current BMI is.
Okay,
I was
so
thinking along those lines too.
yeah, requiring a baseline BMI prior to the use of GLP-1 medications, and then for the reauth is updated BMI, right?
Right. So then this form would just have the current one because this is the form to authorize the first use, if I understand correctly, time-wise. I mean, there may be historical information of previous weights and BMIs, but what we want for this is to have the current BMI before they initiate these medications. Is that correct?
Yes. So we can maybe we can cross out the current BMI here and then put the updated BMI at the reauth criteria, so it will be more clear to the providers, right?
Yeah, I think the idea behind putting differentiating between a baseline and a current is because we wanted to see that how the patient has failed lifestyle modifications. So if their BMI before lifestyle modifications was a certain number, want to know the baseline, and then the current BMI after lifestyle modifications, that would tell us like they failed that, and then and they're eligible to move on to the GLP-1 medications. Does that make sense?
It does, but I wasn't clear that that's what the clinician would understand baseline meant prior to lifestyle modification.
Okay.
If we want to include that, then I think we should put a little asterisk or something that says BMI, you know, that's historical, and for some, if there's no time reference, then we want to indicate that we mean that is before lifestyle modification.
Yeah, yeah, that totally makes sense. So yeah, we can definitely clarify more at the for the baseline and current, like under the criterion 1.
Yeah, and that's for the weight and the BMI that would go together. Height isn't going to change, I'm assuming.
Yeah.
It might for the pediatric patients.
Yeah, for the pediatric.
Oh, I'm sorry. Of course. Of course.
As a pediatrician, yeah.
Yes, thank you. That was my bias showing. Okay, so I think that's just a clarification to, you know, what information we want there. And some adjustment to the language for clarification, as was already discussed. Other comments, questions? Dr. Smith?
And I hopefully you haven't missed it, but is there a question about BMI percentile for pediatrics in here?
Yeah, is 95 or greater, like here and
Okay,
here.
it's just
Yeah.
under the specific. Gotcha. Thank you.
Yep, you're welcome.
Is there sufficient edit to have to review this again, or can we entertain a motion to approve with the suggested edits?
For your information, Utah Medicare fee-for-service will start covering for GLP for weight loss from July 1st. So yeah, so we can make the edit as discussed during the meeting, and then we can post it July 1st.
Yeah, I think we should make a motion and just that we will clarify what baseline versus current mean so that we can get the accurate information from the provider.
Right. And also those language clarifications that Dr. Siegfried also gave us some good examples.
Yes.
I would entertain a motion then to approve this PA with those suggested edits as discussed.
So moved.
And do I have a second?
I'll second with the changes.
Thank you both. All in favor?
Aye.
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 Okay, thank you for that.
Thank you.
How's our time for our last agenda item?
So I'm going to try my best to go through it. It's for Zynteglo, and this is gene therapy for beta thalassemia. And let me see, I'm going to make it bigger here. All right, Zynteglo. So I'll go through the approval criteria. Is a patient 4 years of age or older? Has a patient been diagnosed with beta thalassemia with a confirmed genotype of non beta 0, which that means that the patient has reduced beta globin protein, or beta 0, which is a more severe form of beta thalassemia, where the patient has no beta globin protein, requiring the red blood cell transfusions, more severe form. And so number 3 is the medication being prescribed by or in consultation with the hematologist. Will Zynteglo be administered to the patient at a qualified treatment center? Is the patient considered to be transfusion dependent? Described as one of the following. Receive transfusions of at least 100 milliliters per kilogram of body weight per year of packed red blood cells for the past 2 years, or received 8 or more transfusions of packed red blood cells per year for the past 2 years. Does the provider find that the patient has none of the following conditions? Active bacterial, fungal, parasitic, or viral infections, evidence of severe iron overload, a myocardial iron T2 star value of less than 10 milliseconds via magnetic resonance imaging, and or a liver iron concentration greater than or equal to 50 milligrams per gram. History of any prior or current malignancy, with the exception of adequately treated cone biopsied in situ carcinoma of the cervix, uteri, and basal or squamous cell carcinoma of the skin, myeloproliferative or significant immunodeficiency disorder, immediate family member, parent, or sibling with a known familial cancer syndrome, pregnancy as shown with a negative pregnancy test within the previous 30 days, uncorrected bleeding disorder, a white blood cell count less than 3 times 10 to the 9th per liter, and or platelet count less than 100 times 10 to the 9th per liter, not related to hyperplinism. The patient does not have advanced liver disease. A persistent aspartate transaminase, alanine transaminase, or direct bilirubin greater than 3 times the upper limit of normal, or baseline prothrombin time or partial thromboplastin time greater than 1.5 times the upper limit of normal, suspected or arising from liver disease, or MRI of the liver demonstrating clear evidence of cirrhosis, or MRI findings suggestive of significant active hepatitis or bridging fibrosis. Is the patient eligible to undergo hematopoietic stem cell transplantation and has not previously received AASCT? Does the patient meet one of the following? Patient does not have a human leukocyte antigen HLA matched donor, or patient has an HLA matched donor, but the individual is not available or is not willing to donate. Does the patient attest that the following will be performed once it is confirmed that a hematopoietic stem cell transplant is appropriate for the patient in preparation for receiving Zynteglo? So all of these are in preparation for the actual receiving of the gene therapy. And does the provider attest to counseling the patient on the following? Effective use of contraception during treatment, increased risk of bleeding due to delayed platelet engraftment, risk of neutrophil engraftment failure, or risk for insertional oncogenesis. Does the provider attest that the patient will not be using Reblozyl concurrently, which is an erythroid mutation agent for anemia? And then, has the patient not previously received gene therapy for beta thalassemia? It is a once per lifetime treatment, so no reauthorization needed. And we did include information regarding this medication, which is an ultra high cost drug, regarding the forms that the provider needs to fill out as well. Given that there are currently no Zynteglo qualified treatment centers in Utah, out-of-state providers must be enrolled or will be enrolled with Utah's Medicaid program on or before the date of service. And that is it.
Thank you. Dr. Smith.
I just had a couple of small things, hopefully. Number 5 on the first checkbox, the wording is a little backwards, I think. Maybe it should say receive transfusions of at least 100 mils of packed red blood cells per kilo of body weight per year for the past 2 years. Does that make sense? Just move that.
Yes, thank you for clarification.
And then this, is that okay?
Of packed red blood cells, I'm sorry.
Yeah. So yeah, 100 mLs of packed red blood cells.
Per kilogram body weight.
Yeah, right.
For the past 2 years.
Correct.
Thank you.
Yeah, you have per kilogram in the start of that sentence. That just needs to come out. Yeah, there we go. Thank you.
And then the second thing I noticed under 6C, for the, you've got the in situ carcinoma of the cervix, and basal or squamous cell carcinoma of the skin. Should that be an or? Like either cervical carcinoma or carcinoma of the skin? Does that make sense?
Oh, so it's this.
They don't need both cancers.
And
that
basal
and right after that.
Basal cell carcinoma of the skin.
Well,
And
this is with the exception of. So this is a list of things that would be accepted. So I don't know if that's an and or an or.
Yeah, I kind of feel like it should be an or after uteri.
Okay.
You could do basal / squamous if you don't want to do
Yes.
or.
I
Yeah,
like that. It's clearer.
That's all I had.
Thank you, Dr. Smith.
any other comments or suggestions from the board? If not, I'll take a motion to approve the PA form as edited.
Motion to approve.
Thank you. Do I have a second?
I'll second.
Thank you so much. All in favor? Aye.
Aye.
I believe that concludes our very packed agenda for today.
Can we do a motion to adjourn? Thank you.
And I would entertain a motion to adjourn with my gratitude for your participation.
So moved.
Second, thank you all. Have a
Second.
wonderful day.
Yep. Oh, thank you.
Thanks, everyone.
Thank you.
Thank you.